Maria Russo, and I'm with the Department of Family and Support Services. I'd like to thank the Brain Health team for putting this together. Danielle Riley and Kalila Fagan are our two team members with us today. And now it is my great pleasure to introduce Dr. Joshua Cahan, and he is a neurologist specializing in cognitive neurology. His clinical focus is on aging, neurodegeneration, and cognitive conditions that follow medical illnesses. Dr. Cahan completed his medical school at Rosalind Franklin University, followed by residency and fellowship training at the McCaw Medical Center of Northwestern University. Dr. Cahan actively supports the Northwestern Medicine Mesulam Center for Cognitive Neurology and Alzheimer's disease. He is also involved in several clinical trials on Alzheimer's disease and other neurodegenerative disorders. His research focuses on clinical outcomes and biomarkers of neurodegeneration. Since the start of COVID-19 pandemic, Dr. Cahan has been researching, evaluating, and treating cognitive impairment that follows the COVID-19 infection. He helped develop a cognitive rehabilitation program for this emerging disorder with the Shirley Ryan Ability Lab, which has been profiled in the New York Times. Please join me in welcoming Dr. Cahan. Thank you.
All right, thank you so much for that very kind introduction. And I'd just like to add that as part of my clinical practice, I do often see people for evaluations after head injuries, whether it be mild concussions or more severe traumatic brain injury. And we'll just mention, since you mentioned my work in neuro-COVID and brain fog that can follow that actually our approach to rehab that we took was based off of our clinical experience in rehabilitation for a traumatic brain injury, and drawing upon that experience was really valuable in setting that program up. So I am also incredibly honored to be hosted by the city of Chicago, greatest city in the world. Love the city, love the people, and thank you so much for choosing to spend some time this afternoon with me. I'm so happy that I can share some knowledge and hope to keep the city safe and healthy. So without further ado, why don't we get started? So we gotta first lay the groundwork. What are our objectives today? And we want to learn about what's the impact of head trauma in the general population. There was no pun intended there, but I could see how there might be one sitting there. But well, it's actually a really major health problem, especially as people age. And this talk is kind of geared towards preventing falls, particularly with aging. And we also want to understand the mechanisms behind how traumatic brain injury impacts the brain, and also learn about how those mechanisms may impact cognition and which parts of cognition are impacted, since that is one of the major problems after brain injury. And then we also want to learn about treatment and prevention strategies. So with that groundwork laid, why don't we move forward? And there's kind of a mix of data from the CDC that I presented here. So I have 2.8 million traumatic brain injury, or TBI related emergency room visits, hospitalizations, or deaths in 2013. And that was a total of 56,000 deaths that year. So it's a pretty startling amount of encounters. That's not to say that 2.8 million different people had trauma, but it is a lot of encounters. And even as recently as 2020, there was about 176 deaths per day on account of traumatic brain injury. And it depends based a little bit on which age group you're in, but for everybody, falls are the most common cause, But really the trend is for younger individuals, like less than 15 years old, it's falls. And then also over 55, 65, it's falls. And then that as soon as people start driving into their middle age, it's motor vehicle accidents. That's the most common cause. But really falls generally are the most common across the entire population. And in particular, people over 75, so older people, are at the greatest risk of traumatic brain injury, and that is mostly due to falls. And so there are actually around 2,000 incidents per 100,000 people, which is pretty startling that it's a bit over 1 in 50 people per year will have a traumatic brain injury in the over 75 population. And before we start to talk about, how does this work and what this means and how do we prevent it, how do we treat it, well, we first have to understand kind of what our approach is. How do neurologists think about traumatic brain injury? And the best place to start is really just the anatomy. Where is it impacting? The physiology, what's going on in those areas, and then the pathophysiology, what goes wrong in those places that previously was working normally. And so in the first place let's start on kind of the outside. The protective shell that lines the brain, which is our skull, provides fairly decent protection. And then what I'm really trying to point out here is that under, let's see if I can get a little pointer. Let's get a laser pointer. You see this pointer? All right. So we have the skull, but then under the skull, we have these different layers that help to protect the brain. And in between these layers is spinal fluid. There are also these little blood vessels that kind of traverse the course. And then underneath all this is the brain. And that fluid and the lining helps to kind of protect the brain, keep it in place, and prevent injury from impacts. I'm sorry, I'm missing a slide here. I don't know what happened to it. We'll go here, we'll jump ahead a little bit. And then back to the getting deep underneath those layers, we have the different lobes of the brain. And so there's the occipital lobe in the back, which is in charge of vision. And then there's the parietal lobe, which is in charge of things like mathematical abilities, but also your spatial attention and higher order vision processing. And then we have this little lobe down here called the temporal lobe, which is right under your temples, which is why it's called that. And that's important for language, but especially important for memory as well. And then we have these frontal lobes, which are in charge of controlling our actions and personality and higher order thinking processes. And really, what I was hoping to do is to say that, yes, we have these kind of discrete lobes where these functions lie, but a lot of the higher order thinking processes, while they may be focused in the frontal lobe, are widely distributed across different parts of the brain as part of these major neurocognitive networks. And what we'll mostly talk about here today are the executive working memory network, also known as the frontal network, because it's the nexus is at that frontal lobe that I showed you, and the memory network, which is housed in the temporal lobe. And all this is going on in the brain, which is connected by a couple thin layers of lining and some bone, but the brain's consistency is really soft. It's actually like jello, so it's very delicate. And even though the skull and the lining of the brain can protect the brain from some of the worst parts of impact, the brain still jostles around a lot, even when the skull and the lining of the brain is doing its best to protect the brain. And we'll go back to this picture now. I highlighted these regions, the temporal lobe and the frontal lobe, which are part of these memory networks and the attention, processing speed, executive function skills that are part of the frontal networks. I highlighted these because these are the lobes that tend to be most impacted by injury. Oftentimes when people fall, they might fall backwards, and that impact of the head may hit the back of the head, but there is the counter-coup reaction, meaning that when that jello-like brain kind of jostles, it may hit the back, but then hits the front again, and then gets more damage actually from that counter-coup reaction. And also, if you hit the front part of the brain, those parts will get injured because it's also nestled very closely to bone. And so there's a very high susceptibility towards bleeding or bruising in those areas specifically with almost any impact. And this is just a picture of this. So this is a gross specimen from a brain done at autopsy. And you can see these black regions in the temporal lobes. We're actually looking at the underside of the brain. So these are some bleeding in the temporal lobes and the frontal lobes. So it's a very classic picture that you'll find sometimes on imaging or at autopsy as somebody's had traumatic brain injury. And this picture on the left here is just to demonstrate, yes, we're looking at the brain from the bottom, but here's the brain on the left side of this picture, and here's the skull on the right side. And you can see that there's this ridge here that just nestles up against the temporal lobe, and same with the frontal lobes, that it's very susceptible to kind of just hitting those areas and causing bruises. And that leads to the problems with attention, processing speed, decision-making, personality that can be seen after brain injury, and also memory. And then I'm going to come back to this lining of the brain that's filled with spinal fluid normally. But as the brain jostles around and moves around, some of these little blood vessels can get shaken too and tear, causing bleeding, which can be a separate mechanism for injury. And that's what this shows. This is a subdural hemorrhage, which is the most common type of hemorrhage. And as you can see on this side of the brain where there's the bleeding, the brain is kind of squished in. It looks a lot smaller than the other side of the brain, and that can be deadly if your brain gets squished in too much, and it can press on critical structures that are in control of breathing and heart rate and other respiratory functions. And here's another type of bleed called the epidural hematoma. These distinctions aren't all that important to you guys, but clinically they're important to us. This is often a sign that somebody's had a fracture in their skull, whereas these types of bleeds are a little bit more common to find. And so let's talk about the mechanisms of traumatic brain injury. And so, of course, there's the primary impact, and the higher speed, the higher the fall, the more impact there's going to be. But then there's an inflammatory cascade that happens. So there's the trauma that causes direct nerve damage, but the body tries to repair that damage, sometimes well, sometimes not so well, because it leads to inflammation, which can then lead to more tissue injury, because these inflammatory cells, they try to eat up the damaged areas, they try to recruit other inflammatory cells, and sometimes it can go a little bit haywire and cause more damage than they intended. And that's actually kind of the thought behind what might mediate things like concussion, where we don't necessarily see bleeding or structural damage to the brain, but we know that there's been kind of some jostling at a microscopic level that then leads to some cellular changes that we won't be able to see on imaging. And, we really don't have a great sense of, but this is the theory behind it. And then there's secondary injury from bleeding. The bleeding can cause direct damage itself that the trauma did not. And then also after seizures, people can even get, or after a traumatic brain injury, people can also get seizures, which can then in and of themselves lead to more injury. And then the third mechanism that I'm not really going to talk about all that much, but I wanted to mention because it's really high in people's minds and very popular in the press, is this thing called chronic traumatic encephalopathy, or CTE, which is different than really this mechanical injury or inflammation or related to bleeding or anything of that sort. It's actually thousands upon thousands of small hits that an NFL player might get, um, or people who are susceptible to chronic repeated head trauma that then leads to abnormal buildup of uh, abnormal proteins in the brain. And then those proteins are what actually causes the damage. And this is an emerging entity. The best evidence for this is really just for professional sports players, although there's increasing evidence that this may occur in military members who are exposed to a lot of blast injuries and victims of domestic violence as well, and police officers too. But it's a pretty rare entity that is really separate from the type of traumatic brain injury that most people need to worry about. So what are the things that we as clinicians are interested in knowing when somebody comes in for a traumatic brain injury? We'll want to know what happened, because that gives us a sense of how serious it may have been and whether we need to do imaging, and how long people had lost consciousness for, if at all. And then what type of confusion did they have? It's very common for people to lose some memories from before the brain injury, also called retrograde amnesia or memory loss. And then it's also common to have some memory loss in the phase immediately afterwards, so anterograde amnesia. And as time goes on, the space that you don't remember beforehand and the space that you don't remember afterwards tends to consolidate a little bit and become smaller. But especially in severe traumatic brain injury, that period can last for days or longer. And then one of the most important things we really need to know is, are people moving all their limbs appropriately? Are they weak on one side or another? Because that may give us a hint that there is a neck injury that we really need to be careful about, and stabilize people's necks before we move them. And it could also give us a clue as to why somebody fell too. So say if you had a stroke, that could be the cause of your fall and the traumatic brain injury. But if people just focus on the fall and don't pay attention to those things, well, that could be missed. So these are the important things that we need to key in on to evaluate people appropriately. And how do we classify traumatic brain injury? Well, there are a few different ways. I'd say really the most useful way for lay people to help us classify and to understand how we would classify traumatic brain injury is really based on the imaging, whether it's abnormal or normal, and based on their level of consciousness. If they have loss of consciousness for 0 to 30 minutes, then that is generally considered a mild TBI, especially if the brain injury or if the imaging is normal. And then, and you may still have some retrograde or anterograde memory loss for up to 24 hours. And then for a moderate to severe traumatic brain injury, you will have loss of consciousness for over 30 minutes, and then less than 24 hours for moderate and greater than 24 hours for severe. And you'll be confused for more than 24 hours in a moderate to severe traumatic brain injury. And imaging in a moderate to severe brain injury is most often abnormal. Most often. I think that if it's normal, people probably are missing something. Maybe you got a CT scan and you missed some subtle things that you'd find on an MRI. It's not always as obvious as the pictures that I showed you. But this classification has important implications for how people do afterwards and how we would treat people. And what are the symptoms of a traumatic brain injury? Well, number one thing a lot of people complain about, cognitive changes. Even with mild traumatic brain injury, and especially headaches. A lot of people have headaches. Some people can have insomnia or feel extra sleepy after they have brain injury. People often, especially in more severe brain injuries, have personality changes, irritability, mood disturbance. They can become agitated or violent sometimes. Dizziness and nausea are very common. And gait imbalance is actually really common too. And especially if there's severe brain injury, like in some of those pictures of the bleeding where one side of the brain was squished, that can lead to weakness on one side of the body or another. And there's a whole host of a lot of different symptoms that people can experience. I mean, it can be very individualized for people. But these are the heavy hitters, the biggest things that people tend to complain about. And so what do we do when somebody has a brain injury, and how do they recover? Well, for mild TBI, which is synonymous with concussion, by the way, mild TBI and concussion are kind of the same terms. There's typically a full recovery within the first week or two, although sometimes it can take up to 3 months. People are generally discharged home after an evaluation in the ER. And, a very small minority of patients actually have long-term persistent symptoms. This is often called a post-concussive syndrome. But actually, that's a problem that is really more common in younger individuals. And oftentimes, it's not necessarily due to brain damage, but may be related to overlapping medical conditions or emotional disturbance that has come from the brain injury, from the trauma or the brain injury itself. And actually people with mild TBI and concussion, people even try to avoid some of these terms like brain injury when they talk to patients, because there's some thinking that maybe it would, cause people to kind of fixate on these deficits that really should be getting better in a few weeks. And it's really the more the moderate to severe traumatic brain injury where people have a longer, more challenging recovery and may have lingering symptoms that may be with them for the rest of their life. And how do we treat this? Well, it kind of depends on how severe it is and what's going on. If there's bleeding, typically you want to be evaluated by a neurosurgeon, because if you don't need surgery right away, you may need surgery down the line, say if the bleed expands while you're being monitored in the hospital. And then people with moderate to severe traumatic brain injury often need monitoring in the ICU just to make sure that they're stable. Or if they have poor mental status, they may need mechanical ventilation so that they can breathe appropriately. Because if your mental status is poor, you're not protecting your airway, you're at very high risk of having things like pneumonias or essentially choking on your own saliva. So moderate to severe TBI has much longer course, much more challenging. And in general, the principle for recovery from TBI is that you want to do a graduated return to activities. So you may want to take the first week off or so, say if you have a mild TBI, and then after the first week, you want to maybe take some walks around the block, see how you do with physical activity, and then try some more cognitively stimulating activities like puzzles or reading. And then you can slowly start to increase your endurance by increasing the amount of time that you dedicate to these things. And all while you're doing this, you want to pay very close attention to your symptoms, because the mantra that we have is you want to work to your symptoms, not through your symptoms. And the thinking is that if you're trying to push yourself through symptoms of a concussion or TBI, that it may prolong your recovery. And a lot of my patients do report that, maybe the headaches or the dizziness get worse with either cognitive or physical exertion. And so they really need to understand their body, know what their limits are, while they're trying to also increase those limits too. And that is a lot easier said than done. And especially transitioning back to things like driving or work or managing finances can be a little nerve-wracking to patients too. And those are generally the things that people get to last. But you're not alone in this. And there are certainly health professionals that can help you out, like a neurologist like myself. But what I'll often do is I'll often refer people to physical therapy so they can work on balance. And that's not just important from a, what are the impacts of your TBI? Well, as I discussed earlier, the likely cause of the TBI was a fall. So we want to make sure that it doesn't happen again and make sure that we're addressing any underlying balance or walking problems. And then occupational therapy can play an important role too, particularly if people are having vision problems or having difficulty managing their activities of daily living, like organizing medications, using the shower, using the bathroom appropriately. And then speech therapy, a lot of people are a little bit surprised by this when I mention speech therapy. They're like, well, I'm not having problems speaking, I'm having problems remembering. And actually speech therapy are our go-to people for teaching our patients memory enhancement techniques, giving you exercises to strengthen those parts of the brain that may have been damaged, and giving people really strategies to cope with their new symptoms. And then, the types of medications and the kinds of medications that you can use to treat the symptoms of a traumatic brain injury are really quite extensive and beyond the scope of this talk. But in general, we would treat headaches and any other, and mood disturbance, behavioral problems, seizures with appropriate medications directed towards those symptoms. But there are some medications that may help. And we also really need to optimize sleep, hearing, and vision, because if you're not getting good sleep, you're not going to recover well. Your brain needs that time to repair itself, consolidate memories, and your body needs that time to rest. And hearing and vision are very important because if you're having cognitive problems after your traumatic brain injury, well, you really want to get all the information with the highest fidelity you can into that system so it can use that information the best it can. So, if you're already having trouble to begin with, you want to make sure that you're getting the most accurate and full information so your brain can make the most of it. And in addition, correcting hearing and vision are also important for preventing falls. If you can't see, you're more likely to trip. If you're not hearing as well, you may be a little bit less aware of your surroundings or what's going on, and may lead to falls too. And okay, and so what are the things that we do to prevent traumatic brain injury? Well, you want to exercise caution when driving. And as people age, we always need to revisit, is it appropriate for people to drive, whether it's due to hearing or vision or cognitive changes. And we also, if we're biking or doing other kind of action sports, skiing, what have you, rollerblading, you got to wear a helmet, protect that noggin. And in general, choose your activities wisely. For older populations, things like water aerobics are very, very good, seated and standing exercises. And you want to make sure that if you do consult with physical therapy, that they give you some good tips on what are ways that I can stay active that are good for me and my body. And fall prevention is worthy of another slide, so I'll do that here. And so staying physically fit is really important for fall prevention, as I had mentioned. And some things that actually have pretty good evidence behind it are Tai Chi and dance. And that's actually, I find, a little bit more fun than lifting weights or running. So maybe that's attractive to you. And physical therapy, we don't need to wait for a fall. If you feel a little bit unbalanced, or you just feel like walking is different for you, or you're slowing down, that's a good time to just get in with a physical therapist, see what tips and tricks they can teach you. They may recommend that you use a cane or a walker, and it's okay to use that before you fall. In fact, that is preferred, that you try those things before you need those things. And I know a lot of people are really reluctant to use their cane or walker, but once you start using it, nobody really comments on it. It's not embarrassing, it's appropriate, it's smart, and it will keep you safe and keep you independent for longer. I really cannot emphasize that enough. It feels like it's a step that's taking away our independence, but really it's something that is helping us to maintain our mobility and maintain our independence. So another important thing is, as people get older, their medication lists get longer, and there may be interactions, or people may be on medications that they don't need anymore. And some of these medications can lead to things like lightheadedness or low blood pressure that cause people to fall, or be sedating and lead people to be less aware of their surroundings, or just tired when they're walking, and so they make mistakes. And then we also need to ensure that we're using appropriate footwear. Even when we're hanging around the house, we don't want to be wearing slippery socks. We want to make sure that there are non-skid rubber soles with low heels. So safe footwear even while we're inside. And then I mentioned hearing and vision correction earlier. And there's a whole host of home adaptations. This is by no means a comprehensive list, but it's a good one, I think. It's a good place to get started. And one of the things is that soft carpeting is better for people to fall on because it is a little bit more forgiving. And it also has better grip than, say, a hardwood floor, which is a little bit more susceptible to falls, especially if you spill liquids or wearing socks or barefoot. And then along that same line with carpeting, we got to pay attention to the thresholds or the transitions in our apartments to make sure that they're even, make sure that we're not going to trip over them, make sure that we are aware of them. If there's any change in the texture of the floor, since that can throw people for a loop. Got to have appropriate grab bars and handrails, particularly in the bathroom and shower. That's a very common place for people to fall, and especially on the stairs, because falling on the stairs is pretty serious, and it helps you stay stable. We got to make sure that lighting is appropriate, especially at night. As we age, people are getting up more because their sleep is less deep. Also, people have to get up to use the bathroom more as they age. So making sure that there are night lights, especially near the bathrooms and high use areas, and just even during the daytime, ensuring that there's adequate lighting that helps us with our depth perception and other things that will prevent falls. You can get mechanical lifts for getting disabled loved ones, or for yourself to get in and out of bed, or transition between positions, or even help you get up and down stairs. Another really important thing is trying to reduce clutter so people don't trip, and so the home is easy to navigate. And some areas without carpeting may benefit from some non-slip mats. Most people probably don't want carpeting in their bathroom, so that's one area where a non-slip mat is a good place to have. And then these are just some recommendations. There are a lot of other recommendations that could be made, but it's kind of individualized. And I just want to let people know, I mentioned that occupational therapy can evaluate people's activities of daily living and vision, and help with some other things. But one of the things that they help with is they can visit your home for a home safety evaluation and make some recommendations there. And there are also some resources that people can reach out to like the National Resource Center on Supportive Housing, this organization Rebuilding Together, the National Falls Prevention Resource Center. These are all organizations that can help people modify their homes or give people tips to make it safe. And then I mentioned the Shirley Ryan Ability Lab Brain Injury Center. They really are a world-class brain injury center that is affiliated with our university. And that's where we have collaborated on our post-COVID work. And yeah, there's the Northwestern Memorial Hospital Mesulam Center for Cognitive Neurology and Alzheimer's disease. There's some good resources on just aging and brain health there, and the Brain Injury Association of America. And I wanted to leave some time for questions. And so we'll open it up.
Okay. If you have questions, feel free to put them in the chat or unmute yourself. And Danielle will look for any questions in the chat and ask Dr. Cahan any of your thoughts. All right.
Well, I'll just mention, oh, sorry.
Go ahead.
Yeah, I'll just mention one thing that, you know, as people age, they become a little bit less resilient to these types of injuries. As we age, the brain is less plastic, less malleable. It doesn't adapt quite as well, but those things are still going on. And that's the process that helps to mediate recovery, the rewiring or plasticity of neurons. So, you know, as we age, that reduction in plasticity kind of leads to more susceptibility to these types of injuries. And so younger people are more likely to have a more robust recovery, particularly with severe and moderate traumatic brain injury. As I said, mild traumatic brain injury, 95% of people get fully better within a few weeks. But you know, as we age, there is this increasing vulnerability to any injury in the brain. And so that's why preventing traumatic brain injury, particularly in our elderly patients, is so incredibly important.
For younger people with traumatic brain injury, what type of rehabilitation is available? You'd mentioned a little bit of PT and
so, yeah, I'm glad you mentioned that question. What I didn't talk about is the different settings that rehabilitation can occur in. So if you're admitted to the hospital for your brain injury, you may get rehab there with physical therapy, occupational therapy, and speech therapy. But oftentimes, what people will go to after they're admitted to the hospital is an acute inpatient rehab. So it kind of feels like you're in a hospital, but you're not there so people can run tests, check labs, and give you medications. You're there so you can go to a gym for several hours a day and work with these therapists on, you know, whatever your specific needs are. And so that's where most people who need rehab will go to after a moderate to severe brain injury. And then for people with who maybe not be interactive after their brain injury, or who had pre-existing memory problems where they think that there isn't as much of a chance for recovery, they may go to a nursing home to receive therapies there. The selection is partly due to insurance reasons and also as to how much and how intensive rehab people can tolerate. So you need to be able to tolerate, I believe, at least 3 hours of rehab a day to qualify for acute inpatient rehab. And then after you're discharged from a nursing facility or an acute inpatient rehab, you'll probably be following with people as an outpatient. And to check in, tune up, make sure that you're on track. And there are even vocational rehab programs for people who are working, who had to take time off from work for their injury. And so these vocational rehab programs are kind of similar combination of occupational speech therapy, but they're really tailored at getting people back into the workforce.
Thank you. I was thinking of the situation that was in the news recently with Bob Saget. How often does somebody have a fall where they don't realize they need to go seek medical care?
That is a good question. I don't have an exact number on how often that happens, but it does happen, particularly because after people have a head trauma, they may have lost consciousness for a minute or two. Maybe they did not. Maybe they fell and they were alone and they didn't remember having lost consciousness. And so they don't quite understand how serious the injury is. And so that's why, really, if you have any head injury with loss of consciousness, you need to be evaluated in the emergency department, unless you're part of a kind of a sports program that already has protocols in place. Um, so yeah, it's not uncommon because after you hit your head, you may not really remember how serious it was. And then oftentimes, if there is bleeding in the brain, there can be a lucid period where people feel perfectly fine. And then only several hours later will they start to get like a splitting headache and feel weak on one side. But unfortunately, if the bleeding expands too quickly, you can die from that because the bleeding will press on critical brain centers that are in charge of breathing and your heart rate. So it's not very common, I'll say that much, but it's a concern, and this is why everybody should get, especially if you're older, everybody should probably get evaluated by a medical professional after they hit their head, but especially if there's loss of consciousness and if you're older.
Thank you.
And then there are medical medications that increase your risk for bleeding, that really, almost any time you hit your head, you really just need to get a CT scan.
And the CT scan looks to make sure that there's no bleeding?
Yeah, that's the best study for bleeding.
Okay.
Yeah. So, yeah.
If we have any questions, feel free to turn your mic on or raise your hand, and we're more than happy. We have about 5 minutes for questions if you need. Andrew, go ahead.
Excuse me.
Unmute your mic.
Thank you. We assist residents who experience wars in different parts of the world, and they're in the United States. And right now, there are thousands of people that might be coming from Ukraine. So, do you see the increase of people who experience PTSD because of the trauma of the wars and other traumatic events? Thank you.
Yeah, this is the thing about war. There is, yes, a lot of physical disability, definitely a lot of traumatic brain injury I'll expect to see in that population. Blast injuries, even if you're not directly impacted by the blast, the force really can cause concussions, if not worse. But being exposed to these things, even if you're not physically impacted by them, is very disturbing and deleterious for brain health. So the way that I kind of like to describe it is that, when people develop PTSD, your brain is kind of on hyper alert. And so anything that may mimic that situation that you were in to even a vague degree brings back this flood of emotions and keeps you hyper alert. And it's not something that anybody has control over. It's the body is doing it itself. And it's the body's way of saying there's danger, there's danger, there's danger, even when there's not. And so say if you're trying to read a book or do your taxes or something, and your body's saying there's danger, there's danger, there's danger, you won't be able to concentrate on what's in front of you. And that will impact, people's thinking, memory, and have some downstream implications for brain health. But that was one of the first things that, it's really tragic whenever you hear about war. But, coming from my field, that was one of the first things that I thought about, that we'll have millions of people with post-traumatic stress disorder after this, and head traumas and other injuries. So, yeah.
Okay, well, if there are no other questions, I'd like to thank you very much, Dr.
Yeah, thanks
Cahan,
for having me.
for coming today and giving us such good information. And we appreciate your time and knowledge on this.
You're very, very welcome. Thanks for listening, everybody. Hope you have a good rest of your afternoon.
All right, thank you very much. Bye-bye.
Bye.
Bye-bye.